How's it going, everyone? Today we'll be discussing the cardiac cycle. So we'll go through the different steps that the heart undergoes in order to eject out blood to the rest of the body. The heart has two main phases. That is diastole, or relaxation, and systole, which is contraction. So now both the atria and the ventricles have cardiac muscle surrounding them. The ventricles are going to have more cardiac muscle surrounding them because they're going to need more pressure and more force in order to eject blood out to the rest of the body. So that's why typically when we refer to diastole and systole, we're talking about ventricular. So even though, again, the cardiac muscle surrounding the atria will have their own phases, typically overall when we refer to these two terms, we're talking about the ventricles. And so during diastole, that is when the ventricles are going to be filling up with blood, and then all of the valves are going to shut, and then as we'll see in a second, the ventricles are going to start contracting, building up pressure, and during that systole period, enough pressure will build up for blood to be ejected out. I said this in the last video, but typically when we refer to cardiac grafts and different variables that affect the heart, we are talking about the left side, in particular the left ventricle, just because it is producing much larger pressures and larger volumes than the right side. But keep in mind that as the cardiac cycle goes on, what we are seeing is that both the left and the right side are going to have the same phases. So the atria are going to contract together, the ventricles contract together. So even though that the left side is producing more pressure when it comes to ejecting blood out to the rest of the systemic circulation, these phases are occurring at the same time for both the left side and the right side. You may remember the different phases of the cardiac cycle, so what I'll do here is just an overall general review, and then we'll talk a little bit more detailed about what is going on in those different phases. So starting first, what we are going to have is called passive ventricular filling. So this is going to be when blood in the right atrium and the left atrium is going to start to enter the ventricles. And so what happens is these atrioventricular valves on both sides are going to open, and gravity is going to pull blood down towards the ventricles. Next, what's going to occur is that the cardiac muscle that surrounds the atria is going to become activated. Now, we're going to have a different lecture next week that discusses the electrical activity of the heart. But just for a brief overview, remember that the conduction starts in the SA node, jumps to the AV node, heads down to the bundle branches, and then up to Purkinje fibers. And this is how all the cardiac muscle gets activated. So when that electrical signal jumps from the SA to AV node, all this muscle surrounding the atria is going to contract. And what that basically ensures is that we get the most blood out of the atria and fill up these ventricles more. Then what's going to happen is that these atrioventricular valves are going to shut. So all four valves that you see here are closed. And then the ventricles, the cardiac muscle surrounding the ventricles is going to receive that electrical signal. And now those cardiac muscle fibers are going to become activated. They're going to contract, start generating tension that builds up pressure inside. But until the pressure on the inside gets greater than the pressure on the outside, these valves are going to remain closed. And that's why it's called isovolumetric ventricular contraction. It's because that these ventricles, they are contracting, but no volume of blood has moved yet. So pressure is being generated on the inside, but no blood has moved to this point, but pressure is building. But when that pressure does exceed the pressure on the outside of these great vessels, what's going to happen is that this pulmonary valve here and the aortic valve are both going to open, and then blood is going to be ejected from these ventricles out to the rest of the body. That phase is called ventricular ejection. And then finally, what's going to occur is that once the blood is ejected from the ventricles, these valves will close, and then these muscle fibers are going to start to relax. And what that does, it helps drop the pressure inside the ventricles. So this way, when these atrioventricular valves open again, blood is going to move and start the cycle from the atria to the ventricles. And that's basically the heart, the cardiac cycle. Every single second, it goes through these 5 different phases. And so now we'll talk a little bit more about the pressures and things that occur during these phases. First, let's begin with atrial systole. Remember that before this phase, the atrioventricular valves opened and blood from the atria is going to start to fill up the ventricles. What's going to occur is that the electrical activity from the SA node is going to spread across the atria and is going to depolarize the cardiac muscle cells that surround the atria. And that is shown in an ECG by the P wave, that's atrial depolarization. And so when those muscle cells surrounding the atria become depolarized, they're going to contract. And when they contract, that means that more blood is going to be ejected from the atrium and fill up the ventricles. But following that contraction, then the atrioventricular valves are going to close. And this is going to start the contraction of the ventricles. And that occurs because that electrical activity is going to make its way down to those cardiac muscle cells that surround the ventricles. And they are going to become depolarized. You see that in the QRS complex of an ECG. So during that QRS complex, the ventricular myocytes, they are becoming depolarized, and then they are going to start to contract. Now, when they contract, they're generating force, and that helps to build up pressure within the ventricles. So you could see here that pressure is building up. But remember, this is an isovolumic and isovolumetric contraction. So pressure is building up, but nothing is being ejected yet from those ventricles. And remember that blood will be ejected when the pressure on the inside of the ventricle exceeds the pressure on the outside, the afterload. And so once that pressure has built up, these valves are open and blood will be ejected from the ventricles. Once enough pressure has built up, this aortic valve is going to open. And so what's that mean? That means that blood is going to be ejected from the ventricles and is going to enter the aorta. So that's what you see in the figure here. Blood decreasing in the ventricles. And where's that blood going? Well, into the circulation. So that's why aortic blood flow is increasing. And so that pressure is generated, builds up. We are ejecting blood out, and that blood is getting out to the rest of the body. Then the aortic valve is going to close. That cardiac muscle starts to relax, so you're going to see that left ventricular pressure drop off. Again, at this point, valves are closed. There's no blood moving out. So, during this isovolumetric relaxation, no movement of blood, pressures are dropping, and the cardiac muscles are relaxed. Then again, the cycle begins, and so that pressure drop is going to lead to a rapid filling of the ventricles. The mitral valve, the atrioventricular valves are both going to open, and that's going to lead to an increase in blood that is then entering the ventricles. Just to make a note about atrial contraction, atrial systole, the contraction of the atria are not required for adequate ventricular filling. That doesn't mean that it's not going to occur. And of course, the atrial contraction does contribute a little bit towards that filling. But at rest, just the opening of the atrioventricular valves and gravity pulling blood down and those low pressures within the ventricle, that is going to really be what causes the ventricles to fill. That blood from the atria, just when those valves open, is just going to fill up the ventricles. And so at slow heart rates, like resting heart rates, that atrial kick contributes very little to the ventricular filling. However, as heart rate increases, that filling time, that diastole period, is reduced, and that's what allows heart rate to accelerate. And so since that time frame is smaller, then the amount of time we have to fill those ventricles is reduced. And that's when atrial contraction, atrial systole, becomes a lot more important to fill up those ventricles. So, for example, when we are exercising and heart rates start to pick up and start to increase, there is an increase in demand for blood around the body, and especially in those skeletal muscles. So we need to get out as much blood as we can during this intense physical activity, but at the same time, we are combating a shorter filling period of those ventricles. So at that point, that atrial contraction becomes a lot more important to keep up stroke volume and to keep up cardiac output when heart rates are high. Last, I want to talk about the process of cardiac myocytes, cardiac muscle cells, becoming activated and contracting. You may remember this from your previous physiology courses as EC coupling. So what's going to happen is that a cardiac muscle fiber is going to become activated from a neighboring cell. And so the membrane of that cardiac muscle cell is going to become depolarized. And that action potential that is carried out throughout the membranes of cardiac muscle cells, it is going to reach a location in the cardiac muscle cell called the T-tubule. And when that electrical activity, when that depolarization hits a specific receptor called a dihydropyridine receptor, or DHPR, it is going to become activated. And what occurs when DHPR receptors become activated is that they are going to open, and extracellular calcium from the outside of the muscle cell is going to enter the intracellular space. And some of that calcium is going to bind to what's called ryanodine receptors on the sarcoplasmic reticulum membrane of these cardiac muscle cells. And so when that extracellular calcium binds to that RYR receptor, now the RYR receptor is going to open, and calcium from the inside of the sarcoplasmic reticulum is going to then enter the intracellular space. Calcium released from the SR is going to bind to troponin on these actin filaments, and once calcium binds to troponin, it shifts the troponin-tropomyosin complex. Myosin heads can then hydrolyze ATP and form cross bridges with actin, and that's what causes the contraction of cardiac sarcomeres. And so they will shorten, produce force that are going to contract and shorten. That's what then causes the ejection of blood out of the heart. And then that calcium is going to be pumped back into the sarcoplasmic reticulum. These cardiac muscle sarcomeres are going to relax, and then the cycle will begin again once that electrical activity hits the T-tubules of this cardiac muscle cell. So we know now that the force that is produced by cardiac muscle cells is going to contribute to the amount of blood that is ejected from the ventricles, known as stroke volume. And we discussed in the last lecture how stroke volume could be affected by the amount of blood that fills the ventricles, known as preload. We also discussed how afterload, or arterial aortic pressure, can also impact stroke volume. But another one that we really haven't discussed is contractility, or the force that's being produced by the cells themselves when they are activated. And so what impacts contractility? What impacts the amount of force, tension that are produced by these cardiac muscle fibers? And the answer to that is going to be calcium. So the more calcium that is released from the sarcoplasmic reticulum and binds to troponin, leading to more cross bridges between myosin and actin, the increase in calcium is going to lead to more cross bridges, which equal a higher tension produced by these cardiac muscle fibers. And so if we want to increase contractility of these cardiac muscle cells, then we would want to increase the amount of calcium being released from the SR. And there are many pharmacological agents, drugs, that do this in our heart muscle cells. And so an inotropic agent, that is an agent that increases contractility, is going to lead to the release of more calcium from the SR. That equals greater cross bridges, that equals being greater forces being produced by the cardiac muscle, and that's going to lead to a higher stroke volume. There are also pharmacological agents that decrease contractility of the heart, such as calcium channel blockers, and that's going to lead to a decreased release of calcium from the sarcoplasmic reticulum. That's going to decrease cross-bridge formation. That's going to decrease the amount of force produced by cardiac muscle, and that will decrease stroke volume. We'll talk a little bit more about this in future lectures, and we'll talk about how not only drugs, but how the body itself, through its nervous system, can impact contractility and thus impact stroke volume. So, main point here, takeaway, that 3 things that impact stroke volume: preload, afterload, which we previously discussed. These are blood volume dependent, but then also contractility, the amount of calcium that's released within these cardiac muscle cells that will lead to either increases or decreases in the force produced by these cardiac muscle cells. That concludes this lecture on the cardiac cycle and EC coupling within cardiac muscle cells. Next week, we'll talk a little bit more about the electrical activity of the heart. And in future lectures, we'll talk more about the nervous system and what role the sympathetic and parasympathetic nervous system plays when it comes to heart rate and stroke volume. Thank you guys so much, and I'll see you next lecture.